This should go without saying for microbiology. We always try to expect the unexpected every day. So, starting off, we have a patient who's 26 years old, female with sickle cell disease, and she presents with vaso-occlusive crisis. Essentially, she has tiny clots that are forming ischemias throughout her body. She's initially started on Levaquin for presumed community-acquired pneumonia. She starts presenting with fevers and chills, so the doctors draw 2 sets of blood cultures, and they broaden their antibiotics to vancomycin, meropenem, and gentamicin. And the patient has no other localizing signs of source or infection. Now, 6 hours later, 2 aerobic blood culture bottles are flagged positive by our BACTEC machines. And we see on the gram stain, gram-positive cocci in pairs. So we set up the blood culture identification panel by BioFire. Also, I have no conflict of interest if anyone's curious. It's just what we have. And we would generate the following report. So we see that BioFire does not detect any organisms that are listed, and the ones to look out for that we would normally see are Enterococcus and Strep. So, next day we observe growth on McConkey agar. And obviously a surprise to us. Does anyone have a guess as to what that might be? There's the McConkey plate. So, non-lactose fermenting rod. And here's the gram stain from the colony, from the plates, clearly gram-negative rod. So the following day, we see that the VITEC identifies it as Acinetobacter. So now we're wondering why the BioFire did not pick it up as Acinetobacter baumannii, because it's complex as a species. But I actually tried asking one of the BioFire people here today about why, maybe what the targets are. They'll get back to me. So can anyone guess which species of Acinetobacter that it might be? There's some good guesses. Turns out, our good friends at the molecular lab, which we have right next door to us, they confirmed the identity through 16S sequencing to be Acinetobacter coccoaceticus. This will not be detected by our BioFire BCID, and it was only susceptible to ampicillin, sulbactam, tobramycin, and poly-B. So here's just a quick overview. I'm sure I don't have to explain to any of you the general biochemicals for Acinetobacter, but it's strictly aerobic, non-modal, it's in the name, akineto means no movement, and bacter means rod. So it's a non-moving rod. It's catalase positive, oxidase negative, indole negative, and nitrate negative. It's kind of a boring organism. So direct spears from blood cultures or any liquid media, as a matter of fact, will often have difficulty decolorizing for reasons we have yet to understand. It's just a widely accepted fact that this is a characteristic of Acinetobacter. And we frequently observe them to be in pairs and clusters and appear to be more coccoid in shape during the stationary growth phase, when the organism is growing and dying at the same rate. Now, the identification to the species level is difficult without molecular methods, simply because species within Acinetobacter are so closely related. They're phenotypically almost inseparable. You can't really tell them apart. So we can't rely on automated systems like VITEC or Microscan to give us a positive ID, or at least a reliable one. Now we have the most clinically relevant species of Acinetobacter are, of course, Acinetobacter baumannii, as we're all aware. The complex species included would be nosocomialis, as well as pittii, but as from direct experience in our lab, apparently no one's ever heard of those two. But they're in there, they're part of that complex. And the other one is Acinetobacter lewiffii. And in terms of Acinetobacter coccoaceticus, it's a rare opportunistic pathogen in regards to human infection, it's mostly saprophyte. It's found in soil, water, and also human gut flora. It's part of our normal microbiome. So now we encounter problems with Acinetobacter as a whole in terms of treating it. We encounter more and more isolates of multi-drug, extreme drug-resistant, and pan-drug-resistant isolates that are becoming more and more difficult to treat. So what do we do when we run out of drugs to treat these bugs with? Well, when I was a senior in my last year of college, I came across an enzyme called LPXC. Now, LPXC is an enzyme responsible for the initial biosynthesis of lipid A. And lipid A serves as an anchor to the gram-negative membrane to attach lipopolysaccharide. It's a highly conserved enzyme among all gram-negative rods, and we know that the shedding of LPS during log phase growth of any gram-negative rod will trigger a cascade of immune responses, leading to surrounding cell death of its host. And this is a very important virulence factor, especially in regards to Acinetobacter baumannii. So now we have LPXC inhibitors. It's a novel class of compounds that will prevent the synthesis of lipid A. And by preventing the synthesis, it has a noticeable bactericidal effect on gram-negative rods that will rely on LPS for the survival of their cell wall. This in turn reduces host inflammatory response via the TLR4 receptor pathway, essentially preventing cytokine storm and protecting the host from over-inflammation. However, this class of compounds is not immune to known antibiotic resistance pathways such as efflux pumps. There is good news. Recent LPXC studies have shown that resistance rates among Enterobacteriaceae species are very infrequent, and that isolates with increased MIC to the inhibitors can still be treated in vivo with regular dosing regimens. They still prove effective even with elevated MIC concentrations. And with LPXC inhibitors as it relates to Acinetobacter, it's actually an interesting relationship. So Acinetobacter baumannii can actually survive without LPS. It doesn't have a bactericidal effect. And the early studies using the first iteration of LPXC compound on mouse models demonstrated complete protection from highly pathogenic Acinetobacter baumannii infection. All mice that were administered with LPXC1 survived. The control mice that were not administered LPXC1, 100% death rate. The compound does not inhibit the growth, it does not kill the bacteria, or it did not kill Acinetobacter baumannii, it merely rendered it non-pathogenic. So thank you very much, and I'll take any questions anyone may or might not have.
Our next and last case will be presented